Good afternoon, everyone. It is wonderful occasion, and in fact, I'm very proud to be part of such a uh, wonderful session on medical device and Digi Expo, in which the sensitivity I could realize of the organizer, where they are giving importance to the green hospital. Since I being the chairperson for the Indian Green Building Council healthcare rating, where we have created a healthcare rating specially for the hospitals and healthcare building, which is exclusive, and I think it is one of its first of its kind in the world. But because here our concern is more towards the infection control, the evidence-based design, connect with nature, how nature become a great healer, and indoor air quality, which has become a more concern after the, post-COVID. So I'm going to cover up right now. I'm just sharing my screen. I'm going to cover up the basic scenario is green hospital post-COVID scenario. The main idea is most of us know the basic component of green hospital, the connecting with nature, daylighting, orientation, rainwater harvesting, etc., etc. So I am not covering that. I am going to cover, which you can always get it in our Indian Green Building Council, that is IGBC website, that is www.igbc.in, where you will also find a healthcare rating, which is free and you can download. And here I am trying to cover how the green hospital post-COVID, what all are the important issues which we are doing. First, understand a green hospital, the focus is patient, supported by facilitator like doctors, nurses, staff, etc. And the infrastructure, which is hospital building, including all department, labs, services, etc. And the environment, where I had already mentioned about evidence-based design, indoor air and environment quality, which is very important because you may have a hospital, but in an enclosed box, you don't even know whether it is raining outside or there is a sunshine outside. The idea is connecting with nature is a great healing effect. So in the green hospital, our concerns are patient care and recovery, energy consumption, safe and desirable environment for healthcare professional and workers, infection control, indoor air and environment quality, light and ventilation, and waste management. Waste management also is having an equal importance for the same. Now, categorization of COVID hospital. When the COVID arrived, the Ministry of Health categorized it in three levels. The COVID hospitals are meant for managing only COVID positive tested individual. So level one was a quarantine facility. So this hospital will provide care for symptomatic COVID patient not requiring oxygen or mechanical ventilation and are having only mild illness. These are general ward which you are just putting them quarantine. Second level was where isolation facility, this hospital can provide oxygen therapy to those needing but not in need of intensive care. So this becomes the second level. This hospital may also have a general ward facility for symptomatic patient with mild illness. After the third one is a critical care facility. So level 3 is a COVID hospital. This is a hospital which can provide both intensive care and care for those needing only supplement oxygen, non-ICU, and they also have a general ward area facility for symptomatic patient with mild illness. So you could see level 1 is only a quarantine. Level 2 is isolation facility with the oxygenation, and level 3 is with the intensive care or a critical care facility. Conversion of operational hospital to makeshift COVID-19. This was another challenge during the COVID which we found. Creating a patient biocontainment unit with a separate entrance in the ED emergency department, disinfectant chamber through which staff and patient need to pass through before coming in, and going out from the premises. Then by converting private room wards into isolation, this was another challenge which we have faced, and creating negative pressurized isolation room and treating exhaust air before leaving into atmosphere, and trapping and killing the bacteria and viruses, that is magnetic filterless technology both in the fresh air and recirculatory air within the premises. You remember that earlier we used to do only filtration was the level. We have got into a purification methodology for the reason in filtration, you will be trapping the pathogen and there will be a colony of pathogen there and you have to kill them. That is where the magnetic filterless technology, we'll say trap and kill technology was introduced, and where we started using the ultraviolet, which I'll be deliberating during our presentation. Making necessary changes in centralized standalone cooling system to incorporate bypass system to create negative pressurized and fan filtered exhaust system, and implication of ultraviolet germicidal irradiation and upper room UVGI in isolation, ICU and OTs. So you might have seen that we have gone so digitized that even the OPDs, this was the initial, software prepared by the NIC where teleconsultation, telemedicine based EOPDs were introduced. People need not go to the hospital and they were given the consultation right on the telemedicine methodology. Now e-Sanjeevani has taken over and it has been very popular nowadays. Teleconsultation for specialists was also introduced very broadly at that time because every district hospital could not approach those AIMS or a major specialist hospital. So they were able to get the teleconsultation. Even in the tier 2, tier 3 cities, the telemedicine kiosks were established, and where you have a high definition video conferencing system that allows a doctor to discuss symptoms with patient, diagnose the condition, and prescribe medication. The kiosk also contains several digital medical devices. Then we got into another problem of government hospital had a major issue of crowd. In AIMS Delhi itself, around 10 to 12,000 footfall in the OPD. So use of technology was the only answer. And for that, initially, they have introduced a regular IT-based technology in which a person was to pick up a token and then wait for his time, as it used to be happening in the various private hospital or even in the railways and airline. But the crowd was so much that in the token area itself, there used to be a, congregation of 3 to 4,000 people, struggling for the token. So then we realized that that is not the answer. So we should have a call center methodology, which is happening now. Today, you can see all the engagement or the appointments are already being done through the network or through the web. And you can go to the portal of AIMS or RML or Safdarjung Hospital or Lady Harding or any government hospital. And then we experimented one more thing in AIMS, like our AIMS Trauma Center. We issued a tab to all the doctors. And in that, we could find the moment patient comes, doctor takes a picture, putting his ID, he gets all the important detail. Doctors are not very comfortable in typing. So in the tab, they can do the writing. And also, there is a possibility that bad handwriting may give medication error. So we had introduced drop menu for all the medicines. One more issue was also resolved, that invariably the patient, when he comes after 2-3 months as a repeat case, he says, I lost my OPD ticket or OPD card. So with the search engine, we will be able to find out all these parameters. So these are the kind of a technology, because you remember one thing, that the technology only can bridge the gap between the shortage of infrastructure and shortage of manpower. So this is how one of the methods. Some of the private institution has started using the robo, because those days the touch surfaces, and that was a infection prone, and that kind of awareness was there. So how to do a, use the robo for these parameters. Then we have started using self-service hospital guide because majority of our people are using the smartphone. In a way, sometime when we analyze, there are certain positive aspect of COVID is that the entire country went digitized so fast that though the National Digital Health Mission was launched by Ministry of Health, but whatever it could have achieved after a decade was achieved a decade earlier. Today, the digital payment and digitization has become need of the hour and everybody is aware of this. So this self-service hospital guide will help reduce the manpower and you can get the information which you need, which you need not ask anybody. You can straight away surf and get it. Then computer card, which is mobile point of care. So mobile workstation for electronic patient record and clinical viewing was possible. Mobile clinical assistance was helping the healthcare workers, and bedside infotainment. We call it information and entertainment together so that a person can also keep working from his hospital bed, because if he is undergone a knee replacement surgery, only thing is his mobility is restricted, but he can keep working with the Wi-Fi and the instrument or the laptop, which he can run his office sitting in the hospital. So these are certain things when we were started working from home, these equipments were utilized. And going mobile point at the point of care, nurse spend 90% working time traveling between nursing station and patient ward. So highly integrated computerized nursing card to optimize patient care process and enable mobile point of care. Today in the government hospital and even in some of the trust run and corporate hospital, shortage of nurses felt. And particularly in our government hospital, we have our own set of standard and it takes a lot of time to fill in those posts. So this is how a replacement that a one nurse can handle much more efficiently and work with this thing with this nursing card. MRI was one of the thing which people were feeling very scary, claustrophobic, etc. So this is the one of the latest of MRI where you could see a pediatric patient continuous contacting during the examination by her mother gives him a very comfort level. Otherwise, he is very scared. And a bariatric patient comfortably imagine the largest patient, their size, the oversized body can be accommodated. And another fear which factor which is for the geriatric patient, so easy patient access to reduce stress and worry. And claustrophobic, open, approachable, and relaxing. That is the kind of this is how I would like to share. You are all equipment manufacturers are part of this conference and symposium. I think the medical device and Digi Expo itself by name it says how digitized advancement is helping in the medical equipment sector, which is helping the healthcare workers as well as the patient at large. Some social distancing in village hospitals were also very strictly followed during the COVID time. And the impact today of emerging technology on hospital post-COVID is pharmaceutical will replace some procedure and will decrease the need for admission to hospital, and newer vaccine will treat as well as prevent disease. Minimal invasive surgery will reduce hospital stay and promote outpatient operation. And robotic surgery is already in place. Sensors will change central laboratories and intensive care units of today. And the digital hospital system and people can communicate in the hospital infrastructure with each other to make the hospital more responsive, agile, and flexible. And up-to-date information improves responsiveness and ease the information bottlenecks and block hospital throughput. And two-way communication between nurse and patient reduces unnecessary walking by nurse, giving them more time to focus on patient care. So you know that in India, Government of India, in Digital India was first launched in our health ministry. We launched the NDHM, that is National Digital Health Mission, which was launched on 15th August 2021. Then followed in PMA Bhim, it is Prime Minister's Ayushman Bharat Health Infrastructure Mission, and PMDHM, which is now actively being working, that is digital health card. One patient, one card all over the India, how they can do. And PMAV's mission was also that during COVID, we have realized that we lacked on testing facility, and at the same time, is a critical care unit was the need of the hour. So all the district are planning to have 150-bedded critical care unit, and the testing laboratory and the network of the testing laboratories are to be done, where the central government is supporting portion of the funding and some of the things are being used by the state funding. So this is how it has been happening. Now the DHM, that is digital health card, is also taken a greater initiative in everywhere. So people can, will create a seamless online platform through provision of wide range of data, information and infrastructure services interoperable. So that today anybody is found in any kind of a thing, the health card or his digital health card will give all the information, vital information, like whether he's a diabetic or hypertensive or anything. And it becomes easy for a doctor to treat a patient when he is carrying this digital card. So in the COVID time, we have seen the severity of disease, the critical were taken care with the mechanical ventilation, severe were taken care by the oxygen therapy, and moderate and mild were taken by isolation. So in the emergency department, we created a robust one-way triage flow for the hospital emergency department and create a referral screening pre-triage unit in front of adjacent to the emergency department access. And this is how, so that a patient before entering has undergone through this process. Now, in the various state, they have started in their district hospital a separate block of infectious disease ward. It can be 30 bedded, 50 bedded, 10 bedded, depending upon the district, this thing. So here you could find how in the doctors and staff's entrance, they enter and get into their room. Nurses, doctors, they go and change. And after that, they get into the clean corridor. From there, they go to the donning area, that is wearing this, having a shower and wearing a sterile suit, and then getting into the corridor where they will be getting in through an ante room to the patient room. And after that, he comes out in the same way in the doffing area where he is removing and changing his clothes and getting into his room back. And the patient has a separate entry where they enter from the other side, and same way when they are out, they are going in the similar direction. That means whether a dead body or the patient. Now, the same thing is shown in a 3D where from the area how a person gets into the change room, and then from there how he gets into the patient room, and patient room is supported with a toilet and bathroom, and then he comes out, change, and again goes back to the place. Even the advanced design concept were developed for the infection control process. You could see here that the black line which is showing is the patient, how he enters into his ward or in his room. And the green line is the flow where staff used to enter. But the red is the after biohazard dumping all these things, they change and come out. So this is how the circulations were worked out for a highly infectious disease suit which was created. And you are all aware of the isolation room in which you could see an empty room, and it was a negative pressure isolation room with the attached toilet facility. And this is a typical COVID-19 ward layout which we developed, that where one side, it has also has the evidence-based design principle that every patient who are there, their bed, they are facing a window, and central portion, you could find an open courtyard. You can have a cross-ventilated ward. And if it is a teaching institution, you can have those, demo room, etc. for the student. And as this toilet and other consultation facility, you can use it as a male ward, female ward, as a separate area. You can use it as a specialist area like cardiology here, cardiac surgery here, neurology here, neurosurgery here. Like that, you can use it. And also, if I just show you a little closer view, you could see that the common wall, which is going to be sharing all the services also, like if I go still closer, and the nursing station will be able to take a note. And here you could see the common wall will be sharing the service. The patient will be able to view outside, is connected with nature, and also being a common area, still he can be separated out. This is how the 3D view will looks like, where we are able to isolate, because in a government, it is a hospital or a public hospital, it becomes difficult to give everyone a private room. So, and also it has a staff concern. We need to support with the available nurse staff. So this is the kind of a ward design which was developed during this thing. And selecting finishes and furniture. Finishes should be cleanable. You have seen extensive cleaning required, so material withstand repeated cleaning. Easy to maintain and repair, has to be durable, resistant to microbial growth, metal, acrylic, mineral, or copper in all touch surface. You have to understand that 80% of the infection happens through touch surface. So use of antimicrobial copper is of a great importance. It kills the bacteria on its own. Only use it on touch surfaces, and then preferably use the product which is non-porous and seamless. Joint means infection. So seamless wall, seamless flooring, and even the wall and the flooring junction where we use the skirting, please cove it, curvature. So right angle is not the right angle in these clinical areas. So these are the few important factors which you have to do. And pre-engineered building, performance based, will be preferred construction technology. It used to happen very fast. The WHO has issued a severe acute respiratory infection treatment center, some guideline, in which the minimum requirement for converting an existing building into a SARI treatment center, an existing building may be repurposed into SARI treatment center if the minimum requirements are met. Minimum ventilation rate of 60 liter per second per patient for mild and moderate wards. Minimum ventilation rate of 160 liter per second per patient for severe and intensive care units, and airflow from clean to dirty zone, and patient and staff flow can be clearly defined and distances respected. All finishes, furniture, patient care equipment can be effectively cleaned and are compatible with the facilities disinfectant. So here you could see, as I had mentioned earlier, a short stay observation ward was the level 1. Then you have a severe case ward, which is called oxygen based. And the third one is the critical case ward. And you could see the staff entry and the lab in center, so that they are able to take care the different parameter, and the morgue and the waste zone is also planned, so that when doing the air conditioning system, you can plan a separate zone for this, and all these three zones can be separated out, and this becomes a patient waiting and entry for when they enter and test. So this becomes a very simple format. Even in the IGBC, we have issued the guideline for these emergency center, which you can see it in our IGBC website. Antimicrobial copper, I just talked about. All touch surface. You need not have a complete copper handle. You can have only copper, because copper is an alloy, and you have to, because copper being a soft material, you have to use it as an alloy, and you can choose the alloy material so that accordingly it can match the decor. And you could see even the scissor, and in an intensive care unit, the over the patient table, IV pole, monitor pen, and even bed lever or visitor armchair, even the stethoscope. And now I'll be talking about the airborne transmission, that the technologies we are using right now, which I spoke in the initial stage, we use pressurization, that is negative pressure in isolation room with respect to surrounding, and positive pressure in OTs or procedure room with respect to surrounding. Dilution, high ventilation rate, air changes per hour, control particle by removal through ventilation. And the third one we used to use as the filtration, use a pre-filter or microwave filter or HEPA filter. And that is what exactly I mentioned to you, that we introduce now the purification, that is destroying infectious agent in air through exposure to UV radiation. UVGI or PHI is the photohydroionization, or HEPA MD. HEPA is high efficiency particulate arrestants. MD is microbial destruction. So we went one step ahead. And we used to use airborne infection isolation, which is AII, which is refers to isolation of patient infected with organisms spread via airborne droplets, like patient from COVID or measles or TB, chickenpox, etc. And we have started using PE, that is protective environment, referred to specialized area of patient whose immune mechanism are deficient or undergone like a stem cell transplant or anything. He has to be taken care because of the infection. He's having a lesser resistance for that. And negative pressure isolation room, we have also issued the guideline in which ward or toilet can be have ward toilet can have a highest, that is room static pressure of minus 20 Pascal with ventilation frequency of 12 times per hour, which is heavily contaminated. And wards can have a minus 15 Pascal with 12 times per hour as a contaminated area. And patient corridor, buffer room, and treatment room can have a minus 10 Pascal with 6 times per hour the ventilation frequency. And medical staff corridor and medical staff office dressing room can have a minus 5 Pascal and 6 times. These are relatively a clean area. And UVGI can be used either on coil or in duct. And upper room UVGI is also, you have to understand that ultraviolet is harmful if it is exposed directly to the skin or the eyes. So therefore, upper room UVGIs, which generally very popular during the tuberculosis wards, etc., now is also become a popular after the COVID effectivity. Then I had explained to you the trap and kill technology designed for all aircon systems. Some people told me, sir, you design very big hospital, but I function a small nursing home in some garages or some residential area, and we use the split AC and this thing, which becomes very difficult, whether we don't know whether to run that AC or not. Then we said, yes, central air cleaner is suitable for all type of HVAC system, such as AHU, air handling unit, or fan coil unit, or ductable, TFA, HRV, cassette, split AC, etc., without any modification. We can even customize the system to fulfill your specific need. How does it work? It kills almost virus kill rate of 99% for H1N1, and bacteria kill rate is 100% kill rate on E. coli, and PM 2.5 reduction, PM 1.0 90% efficiency, and 2.5 95%, and volatile organic compound reduction is 90% efficiency, that is the gases, etc. So it has a three stages. First is impeachment, second is polarization, and third is agglomeration. How it works? So that 100% filtered air, particles filtered up to zero point 0.1 micron size is done. So stage one, we have a pre-filter where graded HDPP long lasing filter effective for PM10. Stage two, effective on microparticles makes them thicker. Here you have a polarization needle which makes them thicker and they are trapped. And stage three is the agglomeration where dual polarity, no arcing, trap and kill germs. Effective on PM 2.5 up to zero point 0.1 neutron. HEPA MD. HEPA MD is high efficiency particulate arrestants, microbial destruction. Here you have four levels of filtration. One, exposition to non-thermal plasma, the things which live and they are captured by electrical media. Then comes the molecular filtration, and fourth is the molecular trapping. So in the microbial destruction, you will be finding destruction of airborne microorganism by exposure to strong electrical field and oxidative species in unique non-thermal plasma chamber. And biological biological decontamination and high efficiency particulate arrestance happens on the second part. And the catalytic conversion, the oxidant chemical species are removed by a catalytic monolith. And finally, the molecular trapping, that is organic, mineral, volatile, molecular pollutants are absorbed onto an activated carbon medium. So it is available in four different forms. One is mobile air decontamination unit, which you can place it like an almirah in any of the area where you need to do the decontamination or you want to purify that air. And there are ceiling air decontamination unit. And this mobile protective environment, which you find, we generally use it for a burn patient who are highly infectious. So you can contain them within this small area and prevent them and give them the right kind of a infection-free environment. And the ceiling diffuser system for the air decontamination in a high infectious risk zone. The sealing jet air sterilization unit is the another form which is using the UV, where UVGI sealing jet is embedded in your false ceiling and the airflow is taken care and this is disinfected. Now, one of the kind, lot of people came up with this that, after the COVID, the guideline issued was the return air also to be ducted. So it becomes difficult for the existing hospital to carry on how to carry on such modification. So this UVC lead based air purification device, this used to be fixed in the diffuser. You could see here in the one of the picture where in the diffusers it is fixed so that it will automatically clean the air, and the blue color it is seeing, it is being a LED, it is harmless. So these are the latest technology which has been already into the system. Then benefits of air disinfection technology are proven protection against the transmission of airborne pathogen, proven benefits to the healthcare sector, effective against MRSA norovirus, and also effective against unpleasant odor. So current CDC, Central for Disease Control guidelines recommend negative pressure room with empty rooms for patient with hemorrhagic fever and use of HEPA respirators by person entering this room when the patient has a prominent cough, vomiting, diarrhea, or hemorrhage. Now, face shield or goggles will help to prevent mucous membrane exposure to potentially aerosolized infectious material in this situation. People during while we were making the protocol and the SOPs, that time we realized if the COVID patient vomits on you, suit, how to handle, and similarly how to protect your eyes and nose, etc. Then COVID robotics becomes one of the popular figure during the COVID. There are robots that are used for contagion and virus control that are able to generate high concentration ultraviolet rays that destroys contagious disease. These can be used most effectively in the decontamination or detoxification of COVID healthcare facility, wards, transport facilities, and the like. So it looks like this, where in the process clinical area you can leave it and within 5 to 10 minutes you can decontaminate the entire area for making usable for the next case. Even the striking solution like light strike robots are there, which can take care of the decontaminating the ward rooms, also into the quickly destroy the pathogen and which can cause infection. So these are pulsed xenon, that is non-mercury bulb, to create full spectrum germicidal light. So these are the latest things which are available, and there are some micro solutions and the scrubbing UV technology, even it cleans your wheelchair, etc. So these are the kind of a thing which were all being used because people were very conscious about the infection control post-COVID. So thank you very much for your kind attention. For any kind of queries, you can always email me on chandrasekhar_54 at yahoo.co.in. Thank you very much for patience listening. Thank you. Thank you all.